Thanks very much, Dr. Raj, and hello to everyone. And I hope you can hear me okay, and there won't be any problems with the sound. But the Victorian Perioperative Council, as you say, has been, we have been formed to promote the best perioperative care before, during, and after surgery. And this goes along the entire patient journey, from referral to preoperative assessment and optimization, intraoperative care, postoperative care, and back to primary care. So this is where we see our opportunities to be effective. And some of the principles that guide us are listening to consumers and engaging them both at a system and an individual level, understanding their values and documenting those values, and delivering outcomes that patients actually want, which is good value care. We can't do this without good data, and the sort of data that we need include the sort of case reviews that come from VASM mortality reviews and second-line assessments, but also from multidisciplinary case reviews where people may have only suffered morbidity. We also are working with VAHI and with Safer Care Victoria on administrative data sets, as Adina was saying, and we'll hope to have more perioperative indicators next year. We would have made more progress in that without what 2020 brought. And we're also promoting health service aggregate reports, which I'll speak a little bit more about later, and engagement by Victorian surgeons and health services with clinical registries, just as Paula was talking about, but also the Anzella and the hip fracture registry. And we can't do all this, and we can't improve things without clinical engagement, which really means the people on the end in this webinar and many others and your colleagues identifying the systemic risks facing the system and in your health services, reviewing perioperative outcomes, and informing and promoting quality improvement. So if we think that our aim is to improve the experience and the outcomes of surgery, before surgery, this will involve shared decision-making, risk assessment, and consent. And that consent will discuss and document the benefits, the risks, and the alternatives to surgery, and the alternative of doing nothing at all. And then taking opportunities to optimize the patient before surgery so that they get the best possible outcome. During surgery, it's about being well prepared for the procedure, for using checklists such as the surgical safety checklist and protocols that deal with rare events that you may have to deal with and don't want to forget something in the heat of the moment. Teamwork, communication, and collaboration between a number of different players in the perioperative space. It's not just all about the surgeons, it's also about anesthetists, perioperative nurses, recovery room nurses, ward nurses, and theater techs, and positioning the patient. There are many, many people who need to collaborate and be part of a team. And also responding to unexpected events. These can be anaphylaxis, these can be bleeding, these can be unexpected injury, these can be malignant hypothermia, things that we just wouldn't expect to happen, but we know they are sometimes going to happen, and we have to respond to them appropriately. And then after surgery, recognizing and responding to deterioration, having effective transitions of care, both in terms of which ward they go to. Do they go to ICU? When are they discharged? When are they transferred? Do they go to rehabilitation? And reflecting and reviewing on the outcomes of care, just as VASM in fact does when there's a mortality, and engaging with clinical quality registries for improvement. And I'll mention these as we go along. Risk assessment is really highly important for the outcome of the patient, because not all patients are the same. Even if we might standardize some of our operations we know that, in fact, the outcome that the patient is going to have is going to depend on who they are and what their functional capacity is, what their comorbidities are they malnourished, do they have sarcopenia, how independent or dependent are they, and are they frail? And we want to avoid death whenever possible. We want to minimize complications. We want to maintain a patient's independence and not see them functionally decline or lose their independence as a result of our surgery. And we don't want either the individual patient nor the system to incur unnecessary high costs that will basically further compromise and impair the delivery of the service to other people. Never mind when an individual patient experiences high costs, that their entire financial security and economic well-being may be impacted by those costs as well. So risk assessment is a really important part of it. At the start of the year, VPCC planned to promote learning in health services and with clinicians from perioperative cardiovascular events, myocardial infarction, stroke, and pulmonary embolism, unplanned return to theatre, and that included making sure that there was better local review of these events, as they are now going to be reported in the hospital-acquired complication list, and also learning from transfers where patients have to go to a higher level of care and care has to be escalated, and from sentinel events that involve the perioperative sector. If I take perioperative cardiovascular events first, these are heart attacks, strokes, and pulmonary emboli that occur in the perioperative period. And why are they important? Because they have a significant impact on the patient in terms of mortality and morbidity. And although only a smaller percentage of them die, most are not reported. And they are not reported to the surgical unit often because they're admitted in a separate admission and often to a different unit, and there may be imperfect communication about that event. But perioperative cardiovascular events are relevant to the before, during, and after of the patient journey. And as almost 50% of PEs and atrial fibrillation-induced thrombotic strokes occur within 30 days, they're most certainly perioperative, even if they're admitted to a different health service or a different unit. And that's where the VAED and being able to track and link data can really help in identifying these events for surgical and perioperative review. The fourth generation definition of myocardial infarction also includes a definition of periprocedural myocardial injury in non-cardiac surgery, which has a high mortality. And you can see that in the table on the right-hand side of your screen. And if we think about what can we do before, during, and after, yes, we can do risk assessment, we can optimize the patient, we can prehabilitate them, we can improve their glycemic control. During surgery, the anesthetic team can control the blood pressure and support the circulation. And afterwards, we can monitor troponin levels, make sure they're nursed in the right area, for example, HDU or ICU if they're high risk, maintain fluid balance to avoid acute kidney injury, and manage their pain to reduce the stress in their system. In Victoria, 3.6 per 10,000 non-cardiac procedures have a myocardial infarction, and when that occurs, the rate of mortality is 25%. So it is significant, it is worth preventing, and it is something that involves the before, during, and after. If we think about atrial fibrillation and the risk of perioperative stroke, the tenfold increase in stroke if you have atrial fibrillation either pre-existing or developing during your perioperative stay in hospital. The before is about risk assessment and getting cardiologist or medical input to optimize the patient and get a plan for what to do about anticoagulation. During, monitoring for cardiovascular events, recognizing these patients are higher risk, and after, having a definite plan to restart anticoagulation balancing the risk of bleeding versus stroke. And as most of us know, most patients would rather bleed than have a stroke. And obtaining cardiological and medical input about when to restart the anticoagulation. There was a patient in my hospital a few years ago who had an operation. The team forgot to restart the anticoagulation. The patient had a stroke on day 29 post-surgery and ended up not dying, so was never discussed by VASM, but ended up in permanent care when they had previously been independent. That's the sort of tragedy we want to avoid in making sure that we address these perioperative cardiovascular events. And pulmonary embolism, we have opportunities there as well. 50% of the ones that occur in public occur during a separate admission, and so are often admitted to a medical unit. And almost 60% of those in private are admitted in a separate admission, and often to the public hospital rather than a private. And we need to connect these dots with 94% of the patients surviving. But we still need to learn from the ones that survive. And we can do things before, during, and after surgery. And the one I'd like to really focus on after surgery is making sure that the patient's also engaged about stopping the clot and making sure the patient is aware of raising any issues about DVT or possible symptoms and signs of either that or pulmonary embolism. And in our hospital a year ago, we had a patient who had minor surgery who was seen on the day before they died of their PE in the outpatient clinic. And there was no note whether there was any discussion between the patient and the person who saw them of DVT. The next area that the VPCC planned to consider was unplanned returns to theatre. And you'll see on the right of your screen a de-identified hospital-acquired complication number 4 by clusters. And this is the sort of report when we looked at it in clusters during the pandemic to see if there were any particular changes. It is important when we focus on surgical unplanned return to theatre for a surgical complication that we realize and message and communicate to the sector that many returns to theatre are not measures of failure. In fact, early return to theatre is often associated with a good outcome and is an appropriate response to deterioration. We have to also recognize that ego, pride, and bias may delay a return to theatre, particularly if an individual surgeon doesn't decide to get that second opinion when they're worried about the patient. And it is important to avoid morbidity becoming mortality by taking a patient back to theatre too late, either from bleeding or from an anastomotic leak or many other causes too. A negative relaparotomy is rarely regretted, and so there should be some negative relaparotomies to ensure we really take every patient back who should go back. And we're going to work with FAHI next year to report unplanned returns to theatre against failure to rescue rates. So we actually have the mortality rate, which in my hospital for general surgery is about 5.5% for mortality from unplanned return to theatre. And so we should be able to save over 90 and perhaps 95% of people that we take back to theatre. And there are things we can do before, during, and after. And the after is really about being vigilant, being decisive, and being humble enough to ask for a second opinion from one of your colleagues. We're going to encourage health services to report an unplanned return to theatre rate. We're also going to ask them provide a report on a regular basis of what the diagnosis was, who it happened to in terms of age and gender, and what the procedure and the issues were, and the outcome. And in this sort of format, so that we can make sure that health services are looking at their unplanned returns to theatre, learning from them, and then they can report in this sort of way up the system. And if we know that that's happening and we know how that's impacting upon the audit meetings. It's being discussed at audit and in the health service clinical governance meeting. There probably isn't much more for the VPCC to do except recognize patterns between health services. The VASM report that came out in October, November has highlighted that the two commonest causes of death in Victoria are the acute abdomen and fractured neck of femur. And we have clinical quality registries for each of these two conditions, but Victorians are not the best at contributing to them, and we really need to promote that, that they do so. So I'd like to talk first about the Australia-New Zealand Emergency Laparotomy Audit for Quality Improvement, with its first report just published last month. And there are only 7 hospitals in Victoria that report to this at the moment, and we need to up that engagement. And the overall mortality is 7.1% across Australia and New Zealand for those health services that take part. And this is work that we did earlier in the year in the indirect impacts group, and we just did it by cluster, but you'll see once again that the Victorian mortality rate is around about 7.1 to 7.2%, very similar rate to that in across Australia and New Zealand. And we're hoping that later on we'll be able to report emergency laparotomy outcomes in a kind of PRISM report as well. But comparing Anzella QI to the National Emergency Laparotomy Audit, which is now on its 6th report in the UK, you can see the before. CT scan reported before surgery, risk assessment documented in the notes, and we don't do terribly well there, and theatre access in an appropriate time frame for the particular condition being treated. And you see once again, there is an issue across Australia and New Zealand with access to theatre for emergency laparotomies, and we can most certainly improve. But we won't improve unless health services are actually looking at these KPIs and trying to match them. The during is really about having a consultant present in theatre and a consultant anaesthetist present in theatre, and we're reasonably good at that on our first report. And the after is about ICU admission for high-risk cases with a mortality risk greater than 10%. And you can see that our mortality in Australia and New Zealand, 7.1%. With we may not be able to do quite as much as we would like about the average length of stay when we compare with the UK, who've been going quite a long time, though I think there are opportunities to reduce this, and that would involve a huge saving if we were able to achieve that. Our hospital in Geelong, you can see that our rate of ICU admission went up, our met calls went down, which would be good for the patients, and our mortality went down as well. We didn't affect postoperative length of stay very much, but we certainly improved the outcomes for the patients. And I would encourage all those of you who represent health services that don't participate in Anzella QI to start doing so, because I think you would see similar rates of improvement. The second, the most common cause of death in Victoria is in the perioperative sector is actually people who suffer a fractured hip. And if we think about the before surgery, it's about documenting their pain, managing their pain, and if possible, giving them a nerve block, and also getting orthogeriatric assessment, which is obtained across Australia in 81%, and documentation of the cognition and cognition impairment recorded in about a quarter of these patients, which is hardly surprising given their age. The hip fracture registry manages to get 81% of patients to surgery within 48 hours. And the Victorian hospitals have 3 exemplars, but they do have 1 or 2 slower ones. And it is the reasons for delay you can see here are often lack of access to theatre, but also delays due to issues with anticoagulation. And this is why the medical input is so important in getting these patients to theatre. And I can tell you that the anesthesia subcommittee of the VPCC that discusses cases spends quite a bit of its time discussing suboptimal management of patients with fractured neck and femur. After surgery, it's about early mobilization, about minimizing the risk of another fracture. These are ANZ hip fracture rates, and the length of stay being getting down to about 7 to 8 days, with half of the patients transitioning to rehabilitation. But it is important to have the physiotherapists to be able to mobilize the patient on the day or the day after surgery, and to do a falls risk assessment and to treat them if they have osteoporosis, which the majority of them do. As the PRISM report already reports in-hospital mortality for fractured neck and femur, you'll see most health services in Victoria have a rate somewhere between 1% and 5%. And there's some variability in the number of patients who die, but you can see that they're fairly much in a cluster. But I said that there are a number of health services that do not participate in the ANZ hip fracture register, who would, if they were trying to match the KPIs, would probably have much better outcomes for the patients that survive. Delivering outcomes to that matter to patients is not just about survival. It's also about, do you get home? And only 2/3 get home at 30 days and 3/4 by 120 days. And only 1/4 of people return to their pre-admission mobility at 120 days. This is pretty important if this is a relative of yours, or if this is you one day, and therefore we really want to have a health system that delivers the outcomes that really matters to these patients in the hip fracture. And therefore we need our health services to be participating in the hip fracture registry, and we need to be reporting against it. So promoting the perioperative best care is really, there are a number of other registries that have been mentioned by Paula already and by Adina, and the VAHI reports themselves, but we need to lift the game in Victoria on Anzella QI, on the hip fracture registry. And as always, we're very grateful for working with the registry like the one that VASM represents. Now, you did ask me to say something about low value care. And 2020 has been a journey from low value to best care. And if I could just say that the timeline for perioperative best care, as we have been looking at certain procedures that were formerly called low value, if we think about the timeline, and I'm sorry that I haven't been able to I have to get Phil to redesign this slide for me, but 2012, Choosing Wisely was launched in North America. And in 2012, Professor Adam El-Shaug produced a paper on 150 potentially low value healthcare practices in the MGA. Choosing Wisely was launched in Australia with NPS Medicine Wise in 2015, the same year that Scott and Duckett put out their paper on professional consensus in defining and reducing low value care. RACS worked from 2015 and 2016 with GSA and with the Association of Otolaryngology or Head and Neck Surgeons to produce their top 5 lists. And in 2019, El-Shaug et al. Published their analysis of 27 low-value procedures using the administrative data set in New South Wales. So in 2020, VPCC provided advice to the department and to SCV on the 27 low-value procedures. In May and June, there was a low-volume task force that was rebranded to be Positive and Proactive Best Care, Best Place Task Force. And in July to December, we've consulted with an expert panel and specialty societies to provide best care advice on 19 procedures, with a further 7 endoscopy and colonoscopy procedures likely to go up next week. And we've been working with VAHI to work on a way for reporting, and you can see that still in the gray for next year. but we are working how to do that without getting unintended consequences. So in terms of identifying that some procedures are done too often and not likely to benefit the patient because they're not done for the correct indications, we need to recognize as a sector there is a potential problem. We need to, in identifying that these procedures might be less value and need to be done for specific indications, we need to avoid perverse and unintended consequences or outcomes. And one of these would be massive waiting list audits in public, where less of these procedures are probably being done. And we need clinicians engaged to inform and to actually educate their teams and their colleagues and directors involved in order to make sure that, in fact, this is a forward-looking, proactive thing, that we're going to put the right patients on the waiting list in the future, either in public or in private. It needs to be multidisciplinary, because some operations that might be indicated might not be indicated when you actually get down to doing a risk assessment. And it needs to be cross-sectional. And certainly this year has seen a lot of cross-sectional work between VAHI, between Safer Care Victoria, and between VPCC on this topic, and the department. It needs resources, and Safer Care Victoria and VAHI have been tremendous at providing those resources, and it's needed multiple revisions to get it right. And I'd like to just say that here's the paper from Adam L. Schaug on the 27 low-value procedures with potential for saving $50 to $100 million, which doesn't sound actually very much when you see how much, but it's still an unnecessary waste in the system. But far worse if you're actually doing a procedure for which there would be little value. And the three that they really targeted were colonoscopy for constipation, that's long-standing constipation under the age of 60, endoscopy for dyspepsia and without red flag symptoms, and sentinel node biopsy for melanoma in situ. Now, David Gyorke assures me that no one at Peter Mac would be doing sentinel node biopsies for melanoma in situ, and that this is certainly not part of regarded as best care to be doing that in Victoria. So I was reassured about that. But certainly the Healthcare Atlas of Variation has shown that colonoscopy and endoscopy, there are probably up to 20% of procedures being done for that may not be offering value. Now, when it came to the asymptomatic or the ultrasound diagnosed inguinal hernia, which is one of the 27 lists, it was easy because GSA and RACS already put something out on that in 2016. And that was out there in the sector, and we've been able to endorse that recommendation. The AOA had done the same thing with their knee joint replacements and with arthroscopy, but we had to call upon a wide range of specialists across the sector to inform us of the 27 very different procedures. I would like to highlight Claire Doherty, who's been our secretariat for the last 6 months, and also all of these clinicians who've been involved in providing that expert advice on the 27 procedures. We are able to make revisions if we've got anything wrong, but here's an example of what's up on the website, and this website down here has the first 19 procedures on it. Carotid endarterectomy, you wouldn't normally do that for an asymptomatic patient, certainly not if they've got less than 70% stenosis, and not without multidisciplinary decision-making with a neurologist and a vascular surgeon making that combined decision. And so that was fairly easy to pick that out, but there was a great risk that carotid endarterectomy on its own would be seen as not a valuable procedure, when you're symptomatic, it is in fact incredibly valuable. And double mastectomy for a patient who has a unilateral breast cancer and is average risk, again, that one we've had input from the Breast Society, and that's been very helpful. And I'm very grateful to all the people who gave us advice. So in summary, promoting the best possible perioperative care requires multidisciplinary input. Even we surgeons can't do it all on our own. It goes across the whole patient journey, before, during, and after surgery. And I think some of the low-hanging fruits about minimizing the risk of perioperative cardiovascular events, reporting unplanned return to theater, and maximizing participation in Anzella QI and the hip fracture registry. And I think there's some value in avoiding low value and promoting best care procedures being done for the right indications, because most of these apparent low value procedures do have their specific indications. Thank you very much.